Hello, I'm Dr. Chris Larson, Program Director for the Minnesota Orthopedic Sports Medicine Institute Fellowship Program. I'd like to welcome you to this panel discussion titled Innovations in Orthopedic Surgery, the Emerging Role of Hip Arthroscopy. This program is intended for orthopedic surgeons and nurses. The learning objectives of this program are to increase awareness of the appropriate use of arthroscopic surgery for patients with selected hip disorders, as well as discuss the advantages and disadvantages of arthroscopy in these conditions. Joining me today are Dr. Bryan Kelly, Associate Professor of Orthopedic Surgery at the Weill Medical College of Cornell University, and the Co-Director of the Center for Hip Pain and Preservation at the Hospital for Special Surgery in New York, and Dr. Asheesh Bedi, Assistant Professor of Orthopedic Surgery at the University of Michigan. Welcome.
Thanks, Chris.
Thank you.
Let's take a minute now to have you answer a polling question. First, we're going to talk about a brief history of hip arthroscopy and some typical indications and contraindications for hip arthroscopy. Berman first reported on hip arthroscopy in cadavers in 1931. Even with traction, he concluded it is manifestly impossible to insert a needle between the head of the femur and the acetabulum. The first report describing the clinical application of hip arthroscopy was in 1939. It was not until the 1980s that hip arthroscopy gained recognition as a technique for diagnosing and treating a variety of intra-articular conditions. With improved techniques and a rapidly evolving understanding of hip-related pathology, the indications for hip arthroscopy for the treatment of both intra- and extra-articular hip pathology have grown significantly and are becoming better defined. Current indications for some intra-articular disorders include labral tears, although it is critical to identify the underlying pathomorphology at work in order to optimize outcomes. Chondropathology can also be managed. The majority of full-thickness lesions are treated with microfracture technique. However, newer techniques are emerging, and we'll see these in the future. Synovial disorders and loose bodies can be managed arthroscopically, such as focal areas of pigmented villous nodular synovitis or synovial chondromatosis. And removal of loose bodies from patients with mechanical symptoms is probably one of the most clear indications for hip arthroscopy. Ligamentum teres pathology can be seen at the time of arthroscopy and is typically managed with the labral debridement. Femoral acetabular impingement may be the most common indication for hip arthroscopy. There is a steep learning curve, and our understanding of these disorders is rapidly evolving. Hip instability can also be assessed and managed in some cases, traumatic instability with loose bodies and labral chondropathology, as well as some cases of atraumatic instability. Hip dysplasia and perthes should be approached with caution, and practitioners should consider corrective osteotomies when appropriate. The indications are unclear as the underlying pathomechanics are not typically corrected with arthroscopy. Indications for extra-articular pathology or problems include snapping hip disorders. Psoas and IT band snapping can be managed when conservative management fails, but there are situations where a release may not be advisable, and we'll talk about this later. The peritrochanteric and subgluteal space are receiving increasing attention with situations such as abductor tendon disruptions, as well as sciatic nerve entrapments, which can be seen in the setting of piriformis syndrome. Hip arthroscopy has emerged as an invaluable tool for the diagnosis and treatment of hip-related pathology. The learning curve is extremely steep, and the indications are becoming better defined as outcome studies are being reported with increasing frequency. So next we're going to have Dr. Kelly talk about his experience with peritrochanteric space disorders and in particular abductor tendon dysfunction.
Thanks, Chris. The area that we're going to talk about has been defined as the peritrochanteric space, and it's really the space that's defined between the lateral aspect of the iliotibial band and the greater trochanter, and in many respects may be analogous to the subacromial space in the shoulder. When we enter the peritrochanteric space, this is a schematic of the setup. You can see the vastus lateralis indicated on the schematic with the greater trochanter, and we're putting the camera directly between the IT band and the trochanter. Diagnostic arthroscopy within the peritrochanteric space commonly occurs in conjunction with working with the intra-articular disorders. So entry into the space typically occurs through the anterior portal, and we can sweep the camera back and forth so we can get a good view of the potential space that exists between the IT band and the greater trochanter. When we initially get into the peritrochanteric space, we can get a good view of all of the structures, including the gluteus maximus tendon. We can see the vastus lateralis with the longitudinal fibers. The sciatic nerve, which Chris had mentioned earlier, is sometimes implicated in deep gluteal pain syndrome, can be dissected out in this space. And we can get all the way up toward the greater trochanter and identify problems with the abductor mechanism as it attaches to the greater trochanter, as well as snapping hip syndromes that cause an irritation and erythema to the greater trochanter from a thickened IT band. So greater trochanteric pain syndrome in general it causes lateral-sided hip pain and tenderness. It's very common in endurance athletes and long-distance runners, and it's oftentimes given the diagnosis of bursitis by the practitioners who initially see these patients. Oftentimes, however, the initial pathology actually occurs with the tendon attachment to the greater trochanter, and we've started to understand ways to better diagnosis with better imaging, and we have treatment strategies for patients with persistent symptoms who have failed non-operative measures. The vast majority of patients who have greater trochanteric pain syndrome respond to conservative management with nonsteroidal anti-inflammatories, physical therapy, and oftentimes the use of corticosteroid injections. In cases where there's recalcitrant pain and actual injury to the gluteus medius and minimus tendons, we will consider surgical repair of these. In terms of workup, radiographic findings that we'll oftentimes see show spurring off of the greater trochanter, where there's some traction spurs from the actual tendon pulling off of the trochanter, and soft tissue imaging through the use of MRI can oftentimes clearly demonstrate the tendon where it's torn off of the bone. There are many similarities between the insertion of the abductor tendons and the rotator cuff tendons in the shoulder, and this has been shown in several studies in the literature back in the late 90s and early 2000s. Dr. Dome presented some similarities between the shoulder rotator cuff and the hip quote-unquote rotator cuff, and I think it's easy for us to understand when we think about shoulder cuff pathology with the amount of stress that's put on the lateral side of the hip, how these tendons can become degenerative and tendinopathy can occur. The footprint anatomy of the abductors is very important to understand. The two main tendons that we're looking at are the gluteus medius and the gluteus minimus tendon. There are 4 different facet attachment sites on the greater trochanter, and each of these facets has a distinct attachment site with the exception of the posterior facet. An arthroscopic approach has now been developed so that we can treat abductor tears in the case of recalcitrant pain and the presence of radiographic and imaging findings that clearly define tendinopathy of the gluteus medius and minimus. Here's an example of a large traction spur that developed in a patient who had greater trochanteric pain syndrome, and the traction spur actually had burred a hole through the tendon, and the tendon was ripped off the bone. So sometimes we have to burr down these traction spurs so that we create a bleeding bed that allows for better tendon fixation to the bone. Here's a typical patient that we'll see. It's an older population than oftentimes we're treating in impingement patients. This was a 65-year-old male who was a triathlete. He was a long-distance runner. He had lateral-sided pain, no real groin pain. It's very important to carefully evaluate their radiographic findings because lateral-sided hip pain and bursitis oftentimes coexist with arthritis. We want to make sure that their underlying problem isn't arthritis that's causing compensatory dysfunction of the abductors. This patient had very good, clear maintenance of the joint space, good offset, which Dr. Larson will talk about in a few minutes. But on the MRI and soft tissue imaging, had clear abductor pathology and an actual tear of the gluteus medius tendon. Here you can see the tendon is detached from the bone. This is marked by the hash marks, and the signal abnormalities in this tendon are typical findings that we see in patients with abductor failure. This is a view of the gluteus minimus tendon. In this case, the gluteus minimus was intact, but due to the persistent pain, we elected to treat this endoscopically. When I treat endoscopically gluteus medius tears, I'll always look in the joint first just to make sure we're not missing any pathology. And this 65-year-old gentleman had an excellent looking joint. The cartilage surfaces were in good condition. Had a small labral tear which wasn't clinically relevant and was gently debrided. In terms of the repair itself, Here's an example of a tear. This is the tendon that's been ripped off the bone. I'm grabbing it with a grasper, and we can actually pull it down to the attachment site where it has been peeled off of the footprint. You can see we can reduce it. What I'm doing now is actually preparing the bone to a bleeding bed so that we can apply anchors similar to the way we would treat a rotator cuff tear in the shoulder. The anchors are placed percutaneously so that we get a good perpendicular angle, and once the anchors are screwed in, we will pass the sutures, and there are a variety of suture passing techniques that we'll use, the goal being to try to reestablish the normal anatomic footprint of the abductor tendon. In this case, we use 2 anchors, and we pass simple sutures using a suture passing device, and we'll pass them sequentially so that we can get a good anatomic footprint repair. In my experience, no 2 tears are really alike, so you really have to look at the anatomy of the tear to figure out what the best configuration of the sutures is. But once you've got good mobilization of the tendon, good bleeding bone on the trochanter, you can really figure out what the best configuration will be, and you can tie the sutures down sequentially and get a good, strong anatomic repair. So the results of abductor repairs, we have a small series of 10 patients with a minimum of 2-year follow-up, where all patients had complete resolution of their pain. 90% had 5 out of 5 strength. One of them had 4 out of 5 strength, but they all maintained their full hip range of motion. They had excellent modified Harris hip scores of 92 points, and 7 out of 10 of the patients said their hip was completely normal, where the other 3 said it was nearly normal. Other peritendinous type approaches for partial tears have been described, but we have very little clinical data supporting this approach at this time. So in conclusion, abductor tears for persistent lateral-sided hip pain oftentimes are the reason why people are having persistent symptoms of what have been described as quote-unquote bursitis. And in patients who have failed non-operative measures, including physical therapy, non-steroidal anti-inflammatories, and corticosteroid injections, a careful assessment of the integrity of their abductor tendons is essential. And now we have alternative surgical treatment strategies for these patients, which have very promising outcomes.
So next we're going to change our focus to femoroacetabular impingement or hip impingement. We're going to give a general overview here. I think there are an increasing number of physicians and nurses who are becoming familiar with this problem. So pincer type impingement is an acetabular-sided problem. Typically there's a deep acetabulum that results in crushing the labrum between the acetabulum and the femoral neck. Cam impingement, on the other hand, is a result of an aspherical head-neck junction, and this can result in anterior superior labral condyle disruptions. When you're evaluating these patients, it's critical to appropriately evaluate your radiographs. You want a well-centered radiograph, about 0 to 3 centimeters between the symphysis and the coccyx. You want to evaluate your lateral center edge angle to evaluate for impingement versus dysplasia. You can evaluate what's called the alpha angle to look at asphericity of the femoral head-neck junction on both the AP views and your lateral X-ray views. You want to look for evidence of what's called a crossover sign, which may be indicative of retroversion. And when you have a prominent ischial spines within the pelvis, as well as when the center of the femoral head is significantly lateral to the posterior wall, that's also indicative of acetabular retroversion. You want to look at your lateral view as well. You can measure the alpha angle, and in the literature that generally the normals are less than 43 to 55 degrees, but there is some variability. There are other variants of pincer type impingement as well. Coxa profunda is present when the teardrop lies medial to the ilioischial line, but most importantly you have to have a deep acetabulum as well. Protrusio acetabuli, on the other hand, is present when the medial aspect of the femoral head lies medial to the ilioischial line. And there are some newer variants of pincer type impingement, such as subspine impingement. The anterior inferior iliac spine is the origin of the rectus tendon and muscle, and that can actually cause impingement when that is significantly prominent, either low or anteriorly, primarily with hip flexion. It can also be associated with cysts that may be seen further lateral than usual or distal than usual, indicative of extra-articular impingement. Preoperative three-dimensional imaging, and at this point CT scanning, is really invaluable when evaluating these patients. It gives you sort of an open surgical dislocation appearance to their hip, You can look at an evaluation of the head-neck junction, the location of the vessels, an evaluation of acetabular version, location of rim fractures and os acetabuli. And if you get additional cuts through the distal femoral condyles, you can also look at femoral neck version. So my personal indications for arthroscopic management of hip impingement include anterolateral cam lesions, mild to moderate acetabular retroversion. Profunda and protrusio can be managed with arthroscopy, although it's a bit more difficult, especially for protrusio. And subspine or AIIS impingement is an evolving concept. Open FAI correction, I think, should be considered for patients with posteriorly based cam lesions, severe acetabular retroversion. Protrusio, especially in younger patients, may be better assessed and managed open. And extraarticular impingement is seen in trochanteric impingement with Perthes, or some cases of subspine impingement may be best managed open. So when you're managing pincer type impingement, typically you're going to take the labrum down or debride the labrum depending on the quality of tissue, perform your rim resection, and then repair or refix the labrum back to the new acetabular rim. When cam impingement is present, you're going to typically perform a femoral resection. And prior to the femoral resection, you want to dynamically assess these hips to validate the cam impingement is present. And then after the resection, you want to dynamically assess them once again to show that you have eliminated the conflict. So this is just an example of a patient who had acetabular retroversion. The preoperative x-rays are on the left. Here's the retroversion, and on the right you see after an arthroscopic rim resection. You can manage more global overcoverage, although this is more difficult and typically requires a three-portal technique, requires more of a global rim resection on the left, and then on the right image you can see more of a global rim resection with normal anaversion and a normal lateral center edge angle. Here are just two examples of patients that had subspine impingement or anterior inferior iliac spine impingement as part of their problem, and on the left is the preoperative image, and on the right you can see the arthroscopic decompression of the anterior inferior iliac spine. Here's just an example of a lateral radiograph with cam impingement on the left and after an arthroscopic femoroplasty on the right. So there are an increasing number of outcome studies looking at results after arthroscopic management of FAI, and the results show that about 70 to 90% of these patients have good to excellent results when chosen appropriately and in the absence of advanced osteoarthritic changes. So in conclusion, arthroscopic FAI correction has a steep learning curve. An accurate diagnosis and meticulous surgical technique may be critical in order to achieve optimal outcomes, and our understanding of hip pathomechanics continue to evolve rapidly. Well, Bryan, I know you have a lot of interest in this area, and you've done some research looking at compensations or the compensatory patterns about the hip as a result of some of these motion limitations from impingement. I wonder if you could just briefly talk to us about how this may affect patients elsewhere, and maybe in particular with some of the athletes that we're evaluating.
Sure. I think it's the most interesting thing in this field for me is the effect of internal rotation losses that are associated with impingement. And in terms of the clinical exam, one of the most important things that I think we should be looking for is what's the motion deficit. And when you're talking about athletic patients, and any athletic endeavor really requires a certain degree of internal rotation across the hip, whether you're hitting a baseball, running, jumping, cutting, or throwing. And in people with impingement, oftentimes their rotation is 0 degrees or at least less than 10. And our estimation is that we probably require approximately 25 degrees of internal rotation to perform most of these types of activities. So we have talked about this a lot, and I think it's appropriate to think about the diagnosis of these problems in terms of layers. It's not just the bone structure that's the problem, but the bone structure is the start of the problem. So the impingement, or layer 1, as we see on the slide here, really gives us what the mechanics of the joint are. And an impingement, whether it's a large cam lesion, a rim lesion, an AIIS impingement lesion, they all limit the internal rotation. And that limited internal rotation, based upon their layer 1 diagnosis, causes a direct injury to the intra-articular structures. That's why the labral tear occurs. But layer 3 is the dynamic muscular layer that lies around the joint, and there's approximately 27 muscles that attach crossing the joint, and these muscles become effective either in a compensatory fashion or an indirect compensatory irritation related to this impingement. So one of the most common examples that we see is the coexistence of athletic pubalgia symptoms or pain in the adductor tendon or rectus abdominis in the association with the male large cam lesion. And our hypothesis is that their layer 1 diagnosis is a cam lesion with decreased internal rotation, which causes a direct injury to their layer 2 cartilage. They get a labral tear, but they get some shortening or chronic contraction of the adductor tendons, which predisposes them to extra-articular injury to this musculature, and they develop chronic adductor tendinopathy or rectus tendinopathy or enthesopathies. And they may in fact come in with a primary complaint of adductor pain, but they radiographically have clear impingement. And there are multiple examples of this. We see proximal hamstring syndrome often in the female impinger, where they have more of a rim impingement, and they may compensatorily try to retro-tilt their pelvis, chronically shorten their hamstring, and predisposes them to chronic hamstring injury. In the dysplastic patient, we see a similar thing that occurs in the abductors. They have this sort of lateral subluxation of the hip due to their lack of coverage, and their abductor tendons are working hard to try to stabilize it, and they develop a chronic tendinitis. So the concept of compensatory muscular dysfunction associated with these problems is becoming more and more understood, and I think it's important when we evaluate these patients that we really try to do it in a systematic way, understand what their mechanics are based upon their radiographs and CAT scans, understanding what the direct injury is to the interarticular structures based upon those mechanics, and try to understand why are some of these compensatory muscular dysfunctions occurring in this dynamic layer. And I think that's the general concept that we're trying to get across.
Thank you, Bryan. So next we're going to have Dr. Bedi, who's going to talk to us about what the evidence is for hip arthroscopy and what the outcomes are in the literature.
Thank you, Chris. As we both talked about here, as Bryan and Chris have talked about, hip arthroscopy is a relatively young field, but they have presented some of the outcomes in hip impingement as well as in peritrochanteric space surgery. Because it is a young field, one of our difficulties is that we don't have a lot of outcomes data to work with. Most of what we have is level 3 and level 4 studies to report on, and not a lot of randomized controlled trials to compare the outcomes of these different procedures. In terms of what we have to work with have been 2 recent systematic reviews that have really tried to summarize what we have available in the literature in this problem. Dr. Cloesy from Washington University in St. Louis has recently published a large series reporting on outcomes from 1950 to 2009 on all the series in the literature. What's always humbling when you look at this series is that from over 2,000 studies that have reported on hip impingement surgery, we really only end up with about 11 different outcome studies that report objective outcomes at mid to short-term follow-up. Our group also looked at this both in terms of an arthroscopic and open surgery type of division to try to understand if arthroscopic surgery is reproducing or at least comparable to the outcomes of open surgical dislocation or approaches to problems like hip impingement. And even in that series, we resulted in 19 papers that reported outcomes that were acceptable to assess short and midterm follow-up. And again, all of these papers are level 3 and level 4 papers to look at arthroscopic and open treatment of FAI. I think 2 limitations for us in this area that Bryan and Chris can certainly comment on that makes this difficult is as our understanding of this field has evolved, our treatment for these problems has evolved. And so many of our open surgical approaches, but as well as arthroscopic approaches, have changed and modified over the years from being isolated labral debridements or addressing of layer 2 problems to addressing the underlying mechanical problems of layer 1 and also some of the compensatory problems of layer 3. Similarly, our outcome scores have not really addressed this young pre-arthritic patient with mechanical hip pain. Many of our outcome measures for problems in the hip have addressed the more arthritic hip patient who's a candidate for an arthroplasty, and outcome scores like the Harris hip scores or modified Harris hip scores often are not sensitive to the problems that are encountered by the athletic patient with the pre-arthritic mechanical problem. As you can see on the slide here, this is a slide from Dr. Cloesy's study looking at the systematic review, and here you can see they were very thorough in surveying all the different world's resources really of outcome studies, and you can see from over 3,000 studies that were met from both electronic and hand-based searches when they reviewed abstracts, only about 20 met the inclusion criteria for patients without significant arthritis with objective problems that were treated with hip arthroscopy or open surgery. And after all of the screening criteria of looking at adequate, acceptable outcomes and validated outcome measures, only 11 articles met the inclusion criteria. These results were actually quite similar to what we reported in our series looking at both arthroscopic and open surgeries. This is a table looking at the open surgical outcomes first reported by Martin Beck and then in a series of other studies, both out of Switzerland but also out of the United States, looking at outcomes after open surgical dislocation. And comparably less studies, but studies on arthroscopy, which as we mentioned evolved from being arthroscopic labral debridement and isolated treatment of central compartment pathology to evolving to more recent studies which have reported on outcomes treating both the mechanical problems of the bone and incongruity of the joint, but also addressing the labral tears and layer 2 problems. I think some summaries, not to belabor all of the individual results, that I think you can take away from both Dr. Cloes's report and Bryan and our report, is that at midterm follow-up, which is what we really have available at this point, something like about 30 to 36 months, you do have improved function and pain relief in approximately 70 to 90% of patients, as Dr. Larson reported. What is encouraging is that this does appear to be independent of the technique, and that the outcomes that have been reported from the open surgical dislocations and open approaches are very much comparable to arthroscopy. One limitation again that we have here is that our more comprehensive approach with arthroscopy to address both the underlying bony deformity but also the soft tissue pathology around the hip is really in its youngest phase. It's more of the short-term outcomes. So I think the hope would be that as we have improved outcome scores and improved follow-up on this more comprehensive approach to treatment, we'll have a better sense of outcomes with this more robust approach. One thing that was very clear, and I think is a standard principle that we can accept from both of these studies, is that patients that had advanced age at the time of surgery, but more importantly had significant chondral degeneration at the time of surgery in the form of osteoarthritis or chondral damage on a preoperative MR, all clearly had a worse prognostic outcome with hip arthroscopy. And the outcome conversion rate to a total hip arthroplasty in both of these series was somewhere between 0 to 25%. And the vast majority of those patients making up that 25% were those that had significant preoperative chondral damage. And that may be a good point for us to take home, which is that those patients you want to approach with significant caution or take a guarded approach to either an arthroscopic or open approach. You know, hip arthroscopy in terms of complications was not significantly different from the open surgical approach in this series. The complication set was different, but in general, when looking at quote-unquote major complications, things like avascular necrosis, iatrogenic fracture from an overzealous osteoplasty, or trochanteric nonunion, which is less of a concern with an arthroscopic approach and more of one with an open surgical dislocation, rates were relatively low, somewhere between 0 to 20%. So I think that does validate that hip arthroscopy, again, once you've moved through that steep learning curve that Dr. Larson talked about, can be a safe approach, but does have some major complications that you simply need to be aware of.
Thanks, Asheesh. I mean, I think certainly we've come a long way, but it's clear at this point, based on the reviews, that we need a lot more information. We need better studies, longer-term follow-up. At this point, I'd like to sort of switch things up a little bit and just talk about some controversial topics in hip arthroscopy and get each of your opinions and respective approaches to dealing with these problems. So the first thing I want to talk about is when managing a patient who comes in with hip dysplasia or Perthes disease. Do you think there's a role for hip arthroscopy in this patient population? And when might you not consider arthroscopy in these patients? And we can start with you, Bryan.
So I think that's a great question. It comes up all of the time. The first thing I'd say is that we traditionally have thought of mechanical hip problems or morphological problems with the hip as a spectrum of a disease where there's dysplasia on one end of the spectrum and impingement on the other, and the perfect hip lies somewhere in the middle. What I think we've all come to realize is that it's much more complicated than that, and there's a lot of overlap between some components that impinge and some that are dysplastic. We oftentimes break up the concepts into dynamic impingement morphological problems and static overload problems. Dynamic impingement problems being the cam lesion, the rim lesion, femoral retroversion, and femoral varus. These are motion-induced conflicts, whereas static overload problems are traditional dysplasia, lateral uncoverage on the socket, anterior uncoverage on the socket, increased femoral anteversion or a valgus orientation. What we've really come to recognize is that you can have one static overload problem and one dynamic impingement problem that can overlap. And in terms of dysplasia, we frequently will find people who have a shallow socket but have a cam lesion as well. The question really becomes, what's the primary mechanical issue? And this really requires a gestalt approach, understanding of what the differences are in clinical exam. The general answer to the question is, what's the role of arthroscopy in dysplasia, is that if dysplasia is the primary mechanical problem, we should probably be very, very cautious about performing arthroscopy in them because we're not addressing the underlying problem. But there are some dysplastic hips that also have coexistent impingement pathology that if we're convinced that the impingement is the primary problem, then treating the impingement and the labral pathology associated with it and not having to deal with the shallow socket may be an appropriate approach in selected individuals.
So Asheesh, there are some people out there that maybe don't see as much of this, and they're not involved with research. Maybe they don't evaluate their radiographs and do their exam exactly the same. But are there some pearls that you could give to help somebody when they're evaluating a patient or a radiograph, certain findings that you would say you really shouldn't consider an arthroscopy in this particular patient with dysplasia or perthes?
Yeah, that's a good point, Chris, and I think Bryan talked about that. I would echo his sentiments that it's very hard to use any one absolute for these patients. As you see more of these patients, you realize there's less and less absolutes you can use in terms of your criteria. But I do think there's certain things that are a harbinger of a poor outcome in these patients, or potentially a poor outcome. Certainly on the history side, if it's somebody who comes in predominantly with lateral pain, often weight-bearing pain that is on the lateral aspect of the hip, often in a younger female, certainly makes me think a little bit about dysplasia, and so that I should consider dysplasia as part of the constellation of mechanical problems in the hip. Certainly the physical exam findings then should corroborate that. If I don't see the patient that has the significant deficits in internal rotation that might indicate a combined deformity, such as loss of offset and dysplasia, I'm a little bit more concerned to think about an arthroscopic approach to that hip as the isolated way to treat that hip. Then certainly the radiographs are one more step of confirmation for me about approaching that patient. If I see the radiographs and there's combined dysmorphology on the femoral side and acetabular side, again, some of the radiographic parameters that you mentioned, a low center edge angle less than 20 degrees or so, findings of significant anaversion or femoral valgus, and very importantly, the angle of the sourceal, if there appears to be lateralization of the femur and widening of the medial clear space, all of those give me a lot of concern about using an isolated arthroscopic approach. I think what's interesting is that even in that particular patient, arthroscopy isn't necessarily have no role. There certainly is some increasing a body of evidence to suggest that arthroscopy in combination with an open approach to address the underlying static problem, such as a periacetabular osteotomy, might be the most comprehensive approach to address the labral pathology and chondral pathology in that patient, but yet not leave the bony deformity untreated. So I would say even in those extreme cases, arthroscopy has potentially a role, but isolated arthroscopy probably should be approached with great caution.
Great, thanks. The next question relates to the psoas tendon, or the iliopsoas. I think we've gone through a phase where we did a lot of iliopsoas lengthening or releases, and I still think it's done fairly frequently. And based on some of the research that you and Bryan have, could you give us some insight as to when we may want to be a little bit more careful about releasing the psoas tendon, or maybe when we should absolutely not release the psoas tendon?
Yeah, the psoas impingement as well as snapping psoas is certainly an area that you can manage and treat with arthroscopy, and there was some excitement and continues to be some excitement about psoas tenotomies or lengthenings to treat those patients. I think for the snapping psoas tendon or internal snapping hip that is refractory to physical therapy and non-operative management, and perhaps has the appropriate diagnostic workup, has the physical exam findings that are consistent with it, had an injection that may provide some symptomatic relief, it's something to be considered. I think one of the dangers as we're learning and understanding more about the hip, and I think what Bryan presented about the interactions between different layers, is we have to then step back and understand why is that patient having those increased stresses or snapping on the psoas. And one thing that I think Bryan's series and work on this has has provided to me is an understanding that looking at those patients that are having increased stress or symptoms from the psoas may in fact reflect problems in other layers of the hip. So patients that are relatively anteriorly undercovered maybe have subtle dysplasia, maybe some degree of capsular laxity or insufficiency, which makes them more dependent on the dynamic stabilizer function of the psoas tendon, may in fact be symptomatic from the psoas but also very dependent on it. And I think what some of the research has shown for us is that patients that have increased femoral anaversion, which may or may not be in association with dysplasia, are stressing the psoas tendon, and while a release or lengthening of that tendon may provide some significant short-term relief, we may be adversely affecting the kinematics of the joint and stability of the joint in a way which will compromise our longer-term outcomes. And I think that's leading us to have a little bit more caution about being very liberal in releasing psoas tendons in those patients. Bryan, you may have some thoughts on that.
No, I agree completely. I think the biggest issue that I've seen as a problem with releasing the psoas is in that patient that Asheesh described with the increased femoral anteversion, where that psoas is becoming dynamically overloaded, and that may be the reason it's snapping and causing symptoms, but it's also functionally stabilizing the joint. So we release it because we think it's causing pain, then all of a sudden we've destabilized the joint even more, and we should probably look for alternative treatment strategies for these patients.
Yeah. Let's take a minute now to have you answer a polling question. Lastly, I just wanted to ask, and we'll start with you, Bryan, what do you see in this relatively young field on the horizon? What's out there over the next decade or 2 decades? Any newer techniques, any newer ways to deal with these patients? Just give us your insight at this point.
I think there's a couple of areas that for me are really exciting. We've talked about impingement as I think that's sort of the workhorse diagnosis for the arthroscopist now. And we understand how to fix labral tears and restore the normal structural mechanics of the bone. What we are not able to do is fix the damage that's occurred, the permanent damage to the cartilage inside the joint. So as Asheesh pointed out in the results are adversely affected by the more cartilage damage there that's present at the index procedure. So I think in the future, we'll have more treatment strategies to not only treat the labral pathology and the underlying pathomechanics of the bone, but also treat the focal areas of permanent cartilage damage so that we can have restoration of that cartilage, so that maybe we can, even if we don't get to that patient quite soon enough, we can reverse some of what are now permanent changes in those patients. And the other area I think that's really exciting is more precise anatomical correction, which I think will be allowed through the use of computer navigation and certain imaging techniques that are evolving. Dr. Bedi has some information about that he's been working on that he might want to comment on.
Yeah, sure. Bryan, I would say the same thing and echo those comments, Chris. For me in 2011, I think as a younger surgeon in the group, I've benefited from people like yourself who have given us these tools to address all these different aspects of the hip, including the peripheral compartment, peritrochanteric compartment, the soft tissues of the hip. One of the challenges I think we have now that hopefully in the next 10 years will be different is knowing when to employ those tools. And it's very difficult now to know what combination of those treatments that we can now effectively reach and achieve arthroscopically is the right surgery. We've done some work, I've done some work in collaboration with Bryan trying to understand the kinematics of the hip, and I think computer modeling and use of CT-based models to understand what are the mechanical conflicts and what's the best combination of surgeries or procedures to achieve the optimal outcome is the future. And one very challenging thing is that the impingement area seems intuitive that in areas where there's more bone, resecting more bone would result in a superior outcome. And I think what we're all understanding is that because of the complexities of the hip in terms of version, the degree of coverage or the degree of deformity, it's very hard to anticipate that and do that on an empiric basis without some tools to assist you in identifying whether instability or impingement or both are the predominant problem and how to address that either via open procedures or arthroscopic procedures or both.
And I would, just to build on that a little bit, I think this concept of we treat their cam lesion, we increase their motion, and then all of a sudden we uncover a new type of impingement, sort of a hidden impingement, is sort of an interesting concept for me. And I think the use of computer modeling to employ what is the optimal treatment and actually see what we've done to the kinematics of the joint in a preoperative templating fashion will allow us to avoid those types of problems in the future that may be where some of the failures that we're seeing now are coming from.
Yeah, thank you. Thanks to my colleagues, Medscape, and to you, our viewers, for joining this interesting discussion. You may now take the CME post-test at the Earn CME link. Please also take a moment to complete the program evaluation that follows. Thank you.